Right now we're going to hear about the equipment, the interfaces, the solutions for all these problems that you've been hearing about, or possible problems. And Dr. Lechtzin is up again, and he's going to be joined by Louis Boitano, who's a respiratory therapist from the Northwest Assisted Breathing Center in Seattle, Washington, the University of Washington. He works with Dr. Josh Bendit up there, and I have yet to decide whether Louis is Josh's right-hand man or whether Josh is Louis's right-hand man, because they're quite a team, and they know a lot about neuromuscular disease. They've treated Duchenne's, Post-Polio, ALS, and especially with non-invasive ventilation, and with this not quite a new form, but a different form of ventilation called mouthpiece ventilation, which Louis is going to demonstrate at the end. So we're very glad to have Louis here and he also is enjoying being here in the sun from Seattle. So Louis, welcome.
Well, I as well want to thank Gladys and Judith and the SALT program for the opportunity to present to you today. I was talking to Gladys as well as to Noah about the fact that we really feel like these types of opportunities are the kind of our best chance to talk directly with patients and provide what we think is one of the most impacting things, and that is to give you as much information as we can regarding neuromuscular respiratory problems and try to enlighten you on what types of alternative therapies are there that can help you, because again, the neuromuscular patient population is, we feel, somewhat underserved. That may be an understatement to say the least, but the fact is that most people don't know about the disease processes as they relate to respiratory function, and trying to give patients or empower patients with as much information as possible so that they can discern and for themselves and try to make the best decisions about what can be the best way to go relative to what their symptoms are is important. So Dr. Lechtzin and I are going to do a kind of a tag team format where we're going to present different aspects of respiratory support therapies, and we're going to do it, Dr. Lechtzin is going to do it in terms of presenting a case presentation, a case of a patient that has specific symptoms and limitation, and what's being done to support that patient, and what he did, I should say, because they're his patients. So I like to think about respiratory support in three components. And the first, of course, the most obvious, is ventilation. We're trying to support ventilation for respiratory insufficiency. Negative pressure ventilation was really the first application of type of ventilation, and that was proliferated by the iron lung during the polio epidemics in the 50s. From that, also chest cuirass as well as a pneumobelt type of therapies were also developed. Well, this was a very integral and important part of respiratory support for patients during that period of time, and so that really kicked things off as far as non-invasive ventilation is concerned. But what it doesn't address is that it's negative pressure ventilation, and because we know that oftentimes there's upper airway weakness with neuromuscular weakness, when you try to use something that pulls air into the lungs, if the upper airway isn't open, the efficiency of this ventilation may not be as good as it needs to be. So other types of ventilation have developed since then, and one of them is the development of ventilators, volume cycle ventilators, and with that, invasive ventilation came into mode for long-term care. Tracheostomy ventilation was the home care support system. So it provides positive pressure ventilation, and it provides a secure means of ventilating a person because you were actually connected to the ventilator. So there was security in having that type of ventilation. But it is invasive ventilation. In the late 70s, early 80s, a type of ventilation called non-invasive ventilation, positive pressure ventilation, was developed, and this was by positive airway through a mask system. And this is really more functional in terms of the patient population because although it was really primarily designed for people with sleep-disordered breathing, it had many benefits that for the neuromuscular patient population. It could be easily applied and removed. It could be used on an as-needed basis because for the most part, people in the early stages of respiratory muscle weakness need it for sleep and don't otherwise need it during the daytime. And it has less complications as compared to tracheostomy ventilation with this potential for infection and complications associated with this invasive airway. I would submit that although non-invasive ventilation was developed for sleep disorder breathing, that in fact the neuromuscular patient population has received the greatest benefit from this therapy. And in fact, if you look at some of the studies that have been done, surveys, it actually, there's really an explosion of home ventilation support that for neuromuscular patients that came about as a result of this non-invasive application. So with that, I'm going to stop and give this to Dr. Lechtzin. And this presentation relates to something somebody talked about CPAP therapy and what's appropriate. So this is really something that's an important take-home. So.
Thank you. Is this working? Yep. Okay. So without further ado, I'm going to talk about a patient I saw. So he was a whoops, got to get the right pointer here. Okay. So there we go. So 42-year-old gentleman who has myotonic dystrophy. Back about 10 years ago, he initially developed shortness of breath. He saw a physician who told him he had asthma and prescribed him an inhaler. And he said that this didn't really change his symptoms, but he sort of cruised along without any real change till about 2007 when he started to notice that he was very tired during the day, and he was referred for a sleep evaluation. And I'll tell you, he actually was seen by a sleep specialist at Johns Hopkins, who's a neurologist by training. And she took an interview and said, well, you're only getting 6 hours of sleep a night. You're probably just sleep deprived, but sleep apnea is certainly common in myotonic dystrophy, so let's have you get a sleep study. He had normal sleep architecture, meaning he fell asleep and went through all the normal stages of sleep. And he had about 3 obstructive events per hour, which generally anything less than 5 is considered normal in non-REM. So if you remember back to high school biology, REM is rapid eye movement sleep, and that's when you're dreaming, and non-REM is everything else. So when he wasn't dreaming, he only had 3 events per hour, but during REM sleep, he had 23 events per hour. So essentially 23 times each hour, he would stop breathing. And so he was diagnosed with moderate REM-related apnea. And so he came back to the sleep. He was told, okay, you have sleep apnea, you need CPAP. And so he came back for a CPAP titration where they would adjust the settings. And what they found was that when he was on 10 centimeters of water, which is a fairly sort of middle-of-the-road level of support for CPAP, it stopped all of his non-REM apneas, but actually it didn't really do anything for his REM apneas. But nevertheless, they said, you've got sleep apnea, use CPAP. They also measured pulmonary function tests around this time and found that his vital capacity was only 44% of predicted, which is severely reduced. He had a maximal inspiratory pressure of 22, where normal is somewhere around 70 or 80, so clearly abnormal, and an elevated carbon dioxide level of 49. So this year, he was continuing to use his CPAP, but said, I'm still not sleeping well, I'm still tired. He told me so he finally came to see me. He saw a different neurologist who said, why don't you see Dr. Lechtzin? And he told me that he just felt like he couldn't get a big breath. He was short of breath when he climbed one flight of stairs, and he was waking up with headaches. I examined him, and I saw that he was using those accessory muscles of respiration that I mentioned. He's using neck muscles and muscles between his ribs to help with his breathing. And so I concluded, yeah, you have respiratory muscle weakness, and you're hypoventilating. We saw his CO2 level was elevated. And so all I did was change him from this CPAP, which stands for continued positive airway pressure, which is a common treatment for obstructive sleep apnea, but doesn't provide any ventilatory support, to positive pressure non-invasive ventilation, commonly referred to as BiPAP, and started him on an inspiratory pressure of 14 and an expiratory pressure of 4. And I just saw him back about a month ago, and he says he feels great, he's very happy, he's sleeping better, he has more energy, and his headaches have resolved. So, turn it back over to Louis.
So bilevel pressure was what he needed. He didn't need CPAP. he actually had quite significant respiratory muscle weakness, so bilevel pressure was the type of support that was going to give him the best support for him. So just so you're aware of these things, as Dr. Lechtzin said, he increased he gave him IPAP, he gave him inspiratory pressure, and this expiratory positive pressure is what gives you the breath, or gives you basically flow, an extra flow of air to augment your breathing on inhalation. And if you noticed, he turned his IPAP from 10 down to 4. So now, instead of worrying about obstruction, he actually just facilitated giving him more support between the IPAP and EPAP, and that's what we call pressure support. This is the augmentative support that allows him to be able to take a bigger breath with the support of that inspiratory pressure. And the expiratory pressure basically allows us to evacuate the gas as he exhales out of the mask. So this is kind of a more fluid means of breathing support, because the machine actually recognizes when you breathe in and breathe out. And so if it's working correctly, it should just follow your breathing pattern. When you breathe in, it should move to the higher IPAP level to give you this extra airflow to help you take a bigger breath. Basically, it decreases your work of breathing. You don't have to breathe in as deeply because the machine does the work. But it doesn't control your breathing. It just allows you to take a bigger breath, so it augments your breathing. The important thing about using BiPAP is that it should always be set up in what we call a ventilation mode. Basically, a BiPAP with what we call an spontaneous time ventilation mode allows you to be able to get the amount of breaths you want when you're breathing. But if you go into REM sleep, this is a period of time, particularly when you have significant breathing muscle weakness, where only the diaphragm is working. Most of the rest of the breathing muscles, in fact, most of the body muscles, with the exception of the diaphragm and the ocular muscles, are in a state of what we call atonia. It's like a semi-paralysis. And so if that diaphragm is weak, it may not be giving you enough effort or making enough effort for you to actually trigger the ventilator into giving you a breath. So the spontaneous component allows you to take breaths and let the machine respond to you as well as you're able to do that when you take breaths. But if you don't take enough breaths relative to a backup rate, then the machine will go into that backup rate and give you X number of breaths per minute, depending upon what the backup rate is. So this is an important component, and oftentimes people with neuromuscular weakness are prescribed a BiPAP system in what we call spontaneous mode without the backup rate, and there's always a potential for a lack of adequate ventilation. If you're not able to trigger that ventilator, it's not going to give you a breath. So this is something that is really integral and important in neuromuscular respiratory support. We think that anybody that doesn't have a backup rate on their system really needs to be moved to that kind of a machine. This is, again, that ventilator feature where you have the timed backup mode, and it provides you with that backup support. Now, these are just a couple of different, or 3 different types of bilevel pressure systems, all have backup modes in them. And we just want to talk about the features just a bit. So what's really important when we set this up, because as opposed to people who are in the hospital who are on a ventilator usually are sedated and they're not aware of what's going on, people use this, so they're in a conscious mode. So it's really important to try to get that system to be in synchrony with your breathing pattern so that there is a good support without you feeling like the machine's controlling your breathing. It's just augmenting your breathing. So different types of settings, or what we call parameters, can be adjusted in order to do that. One of them is rise time. That's the transition time from the exhalation pressure to the inspiratory pressure. We want to make sure that it's in sync with your breathing. How fast do you want that machine to respond to you relative to when you breathe in? We all have kind of a particular breathing pattern, and some of us want that inspiratory pressure on that IPAP to come to us a little bit more gradually, and others of us want it to come quickly. So this is a very particular, and I think a very important thing that needs to be adjusted relative to what you feel is comfortable, and that's the key. It's what you feel is comfortable because you are the user, and it should be, when a person is set up with this, it needs to be addressed. The inspiratory time maximum allows the person who's adjusting this system for you to be able to set it up according to what you feel is adequate time to breathe in. This is important not only in the backup mode, but also in your spontaneous mode. There are, on some ventilators, you have inspiratory and expiratory trigger sensitivities, and these can be adjusted. in order to, again, make the system actually in sync with your breathing. What Dr. Lechtzin did was to provide this gentleman with what's called wide-span bilevel pressure. Again, the difference between the IPAP and the EPAP is what you get in pressure support. If you use a wide-span pressure support, gives you pressure support, pardon me, and the EPAP is meant to, again, just flush the exhaled gas out of the mask so you don't end up rebreathing your own exhaled gas. So you want a higher IPAP and a lower EPAP. Now, if you do have some upper airway associated sleep disordered breathing, you may need to have higher than 3 to 5 centimeters, but depending upon what your situation is, if you don't have any sleep disordered upper airway problems, then what we usually do is default to this. Now, if we're not sure, oftentimes we'll send people for polysomnography testing with a pressure adjustment to determine that. But when we do that, we always try to explicitly send directions to the sleep center to titrate or adjust the pressures so that we're not running into a problem where that pressure support ends up getting narrower, the difference between the two. Because as Dr. Lechtzin said, sometimes when they're actually making the adjustments, they're not aware of neuromuscular sleep disorder problems and how it affects their ventilation. Okay, so the other important component to this, besides the right bilevel pressure system, is the right interface. What is your nasal facial architecture? Are you a primary nasal or oral breather? What's your anatomy in the nose? Have you had any problems with injuries in the past so that you have a deviated septum? Do you have any problems with chronic rhinitis or seasonal rhinitis that can affect nasal congestion and your ability to be able to use a nasal mask as opposed to an oral nasal mask? Claustrophobia is a very significant problem when you have a mask that goes over the face and encroaches in your field of vision. A lot of people are very uncomfortable with this, so that needs to be addressed to determine whether this is a problem for a person, because it can be a significant issue in their ability to acclimate to the use of this breathing support. And bulbar weakness, the oropharyngeal weakness, can be a very big problem in the management of providing non-invasive bilevel pressure ventilation. It's usually necessitates using an oral nasal mask, and oftentimes because of what we call sialuria, or just the inability to control your oral secretions, people will need to use some kind of what we call an anticholinergic medication to manage the secretions such that they don't have problems with secretion management while they're using their mask. And I'm going to stop there and give this to Dr. Lechtzin again to illustrate a case study on interfaces. So, oops, sorry.
Got two.
Oh, cool.
Okay, so this is a patient who at age 54 developed foot drop, and about a year later was diagnosed with ALS. This is a picture of the patient. This is Jeff Rothstein, who's a neurologist who directs our ALS clinic, and they were at a Baltimore Orioles game fundraiser for ALS at the time. So it was early in her disease course. About 2 years after she was diagnosed, she started using non-invasive ventilation. Initially, she was on a setting of 14/4, and she was using a nasal mask, and she used it all night long, and she used it during naps and was doing fairly well. We gradually increased the inspiratory pressure up to 18, but as I said, she was using it quite a bit and eventually developed some skin irritation from the nasal mask. We changed her to a mouthpiece that she was using during the daytime. And then after about 4 years from the time of diagnosis, she got to a point where she was using non-invasive ventilation about 22 hours per day. She got to a point where she was unable to speak. This is, again, the same patient at another ALS fundraiser later on in the disease course. And because she was using it but having difficulty with skin breakdown and fighting interface, we switched her to this total face mask, which essentially looks very similar to a clear hockey mask, covers the entire face. And she did quite well with that for a while, but clearly stated that she did not want a tracheostomy and eventually died peacefully at home.
So there are a lot of different types of nasal and oral nasal mask alternatives, and showing some of the variety, there are masks that have somewhat less amount of hardware up on top here. This is a kind of a newer design that may address some benefit because it kind of integrates a chin strap that supports the orientation of the mask. You have masks that have a gel interface. If you can, there's an actual gel layer between the shell of the mask and the surface of the skin. This is a mask that has kind of an air cushion area. I wish I would have given you a better illustration of it so you could see it. It's behind the shell. And this is something of the same type that has this is something that integrates both the kind of the cushion, the air cushion with gel. So there are a lot of modifications and permutations of these types of masks. And the challenge, to the clinician is always to try to determine, what mask works relative to your facial architecture and the other issues that I noted about nasal and oral function. And of course, the other component is you as a user of this and what works best for you, because you are the end user again, and because again, this type of interface is worn when you're conscious before you go to sleep. It's something you have to get used to. With issues of claustrophobia, there are different types of mask systems, both nasal as well as oral nasal, that allow you to be able to wear a mask without a lot of hardware around the face. And this is the issue with pretty much all, it's addressed by all of these types of masks, both nasal pillow masks as well as nasal shell masks, or in this case, kind of a newest permutation where you have what we call nasal pillows in conjunction with an oral shell. So these masks are all meant to keep an open field of vision. These masks address that problem. They also actually can be used during the daytime when you don't want necessarily, you want the support, but you don't want to have a mask that goes over the face. They provide you with a much freer area to be able to wear the mask without having all the extra hardware. So as a alternative daytime mask, they work quite well for that purpose. And if you're wearing any kind of a nasal mask, we always want to try to use a chin strap in conjunction with that. We know that when people fall asleep, the muscles of the jaw will actually relax, and oftentimes the mouth will fall open. And so the benefit you receive from a nasal mask is significantly compromised for lack of ability to get the air into the lungs because it simply returns out the mouth. So these are different alternatives in chin straps. There are masks that actually integrate what we call a chin cup that actually hold the chin up so it covers, goes underneath the chin, and those are an alternative as well. Again, it's just finding the right combination that works for people. And this is, again, looking at the mask that Dr. Lechtzin had provided for this patient. The newest permutation for this is a mask that's a little bit smaller, and I've found this to be quite helpful for patients who have really significant problems with just fitting any kind of a mask because of a really high nasal bridge peak, or some people have just kind of asymmetric facial architecture and no mask works. And this has kind of been a godsend for me in trying to manage and provide adequate support. There's at least one type of oral alternative too that can be used for special applications if a patient wishes to use that. This is a product that I'm not trying to endorse something, but we had an opportunity to trial this product with some of the patients who really are problematic for having pressure sores on the bridge of the nose. And this particular product has been really, really helpful in terms of managing this nasal pressure issue. It's called a Sleep Comfort Care Pad. It has kind of a soft, adherent, almost really frail kind of looks like an inverted T pad. It's clear. In this case, some of the predecessors were colored, but in any case, it actually provides kind of a barrier between the mask and the skin surface, and has really helped a number of patients where they've had this chronic problem. So we think it's a kind of a tool that can be super helpful in us allowing us to be able to manage patients and provide this support. So it's called the Sleep Comfort Care Pad, and actually Helen Kent has some handouts for information on this. So I think this is an enhancement in the ability to use nasal or even oral nasal masks that go over the bridge of the nose. And the other benefit to this is that we found in some patients where we haven't had to, basically the headgear doesn't have to be strapped on as tightly because the actual pad facilitates the part of the seal. And one of the problems that we've had more in the last few years with patients where we've had to keep increasing the pressure support is that they start to develop what's been called aerophagia, or just air that's passing from the mask through the esophagus into the stomach and causing discomfort as well as compromising the ability to get ventilation, because as you recall, or you may have remembered, if you have a full stomach, then it compromises the ability to provide adequate ventilation. So these are called Farrell valves, and there's a regular Farrell valve and a super valve. It's just a wider container. And what these are meant to do is to actually allow the air in the stomach to purge out. We know we're trying to still ventilate people, but we know that this problem can only be solved by decreasing the pressure support, and that's certainly going to compromise your ventilation. So if we can do something to actually manage getting that air out, the Farrell valve system has worked quite well for a number of our patients. Patients like our Duchenne patient population, where they have gastric immotility problems, have been a patient population where this has worked out quite well. So it reduces air, and it is actually designed to be used with positive airway pressure ventilation, but I don't know that it's that widely used, so it's something to be aware of. The other type of bilevel pressure ventilation, just a modification of that that's come out more lately, is what's called AVAPS, or average volume insured pressure support. So this is a machine where you actually dial in a target tidal volume, and you then put in a maximum and minimum IPAP and allow the machine to adjust. It basically kind of reads the estimated tidal volume that it gives the patient and adjusts the pressure, the IPAP, accordingly to try to maintain an average tidal volume. So it's kind of a smarter BiPAP system. Now, the one good thing about this is that, as the one patient had mentioned, with like diaphragmatic spasms, the machine may misinterpret what's going on and actually try to titrate or push the IPAP up higher than what you want, and then you start to run into gastric insufflation problems. What you can do with this machine is that you can use it either in the BiPAP mode or in the AVAPS mode. So for some patients, we've used this in the AVAPS mode exclusively, and for other patients, we've actually done kind of a trial of therapy where we use it in the AVAPS mode, download the card, see what's happening, see what pressures the machine has titrated the patient to or adjusted to maintain that tidal volume, and then we just set that on the BiPAP and go along, so you can periodically run the AVAPS mode if that's more desirable. On occasion, we've had problems with the machine adjusting the IPAP up, and all of a sudden the patient starts to develop mask leak as the higher IPAPs have been pushed, and that obviously, for the most part, causes problems because then they awaken and they don't feel like they're getting their sleep. It's causing them more problem than helping them. So there's kind of a fine line. This is something where we always wish we had this, and then when we got it, it's one of those be careful what you wish for, because it does create some management issues, but it has the potential to be it's definitely an important tool now, but I think it can be only more important as we learn to use it better. There's a lot of technology that's coming out in non-invasive ventilation, but there is a learning curve for the clinicians to be able to use this as effectively as possible. So again, it's self-adjusting pressure support based on a preset tidal volume. The other thing that you can do with this is pressure control. I haven't had a lot of experience with this, but pressure control is something that can be used if you have persistent problems with the gastric insufflation. So you could try this as an alternative to the bilevel pressure mode, but I'll not say anything more than that for lack of good experience. So moving on to volume cycle ventilators. These are examples of smaller, lighter ventilators that are available today. The trend in the newer ventilators is to have a larger battery, internal battery, that allows the ventilator to operate without the benefit or the need for a dedicated power source. And this is particularly important for portable support. You know, the traditional ventilator patient who stayed home and didn't do much, that's no longer the case. As patients, particularly our younger Duchenne patients and spinal muscular atrophy patients, have been able to do well with non-invasive ventilation. They try to lead as active a lifestyle as possible. They're going to school, they're going to after-school events, and they want power that's going to allow them to be able to stay out of the home and do what they want to do. So the advent of these lighter, smaller ventilators that allow them to have a smaller ventilator package on their chair and to provide them with the ventilatory support they need to be out and about as much as possible, I think has really improved their quality of life significantly. With those ventilators, you can use them in two different modes, and what I'm going to talk about first is volume cycle ventilation by mask. The BiPAP masks that I showed you before are all what we call vented masks. They have some kind of a hole system, some kind of a either a valve or some type of a labyrinth of holes that allow for you to exhale out to the mask. With this type of ventilation, when you use these volume cycle ventilators, you need to use a non-vented mask because there's an exhalation valve in the circuit of the ventilator. So these masks are all identified by having some kind of a off-color plastic shell. It's usually blue, and that indicates that it's not a vented mask, and that's a significant issue because you don't want to be using a non-vented mask on a BiPAP system or vice versa. You'll not get the benefit using volume cycle ventilators with a vented mask. And alternatively, some clinicians have actually taken vented masks and closed off the valves in order to be able to use that because the variety of these types of masks to be used on those volume cycle ventilators is pretty limited at this point. And it was really kind of something that's been used more in the acute care in the hospital arena. And now with the advent of these newer ventilators, these particularly, all of these actually, this is something that's going to be used in the home care arena. Again, it's an issue with what's appropriate, what's the best ventilation for me? If bilevel pressure is working just fine, do I really need to use something like that? And if it's not working well enough for me, what is best for me? And how do we proceed to do that? And again, there's a clinician curve here, a learning curve, because while this type of ventilation with these masks has been used in Europe a lot, it hasn't been used that much in an outpatient setting in the United States. So it's, again, we're moving in this direction, and there are more ventilators available for this application, but it's a process. It's like a culture change. So with that, I'm going to stop because we're going to talk about the other alternative that volume cycle ventilation can be used for.
Thank you. Okay, so I'm going to tell you about a young man with Duchenne muscular dystrophy. Whoops, keep doing that. So 28-year-old with Duchenne muscular dystrophy. He was initially seen in the pediatric pulmonary clinic at age 14 when he developed shortness of breath, cough, and fever, and he was hospitalized for pneumonia, and at that time, he was started on nocturnal non-invasive ventilation. I don't know why it gets cut off, but so he was on that for about 6 years, and then he noted that he started to have symptoms during the day, feeling more short of breath and fatigue during the day. And so he was started on mouthpiece ventilation. So he has a Pulmonetics ventilator, not to advertise a particular brand, but it's one of these. People will sometimes refer to it as a laptop ventilator because it's sort of the shape of a laptop computer. And it mounts very nicely on the back of his wheelchair. And so I saw him for the first time when he was 24. We'll also talk some about mechanical insufflation and exhalation. He was using that 2 to 4 times per day. When I saw him, his end-tidal CO2 was somewhere around 35 to 40, which is normal. He gets a yearly flu shot. He's received his pneumonia vaccine. And really since 1996, when he first came into the hospital, he's had no respiratory infections. He's a math major at a small liberal arts college in Maryland. There's a group of young men with Duchenne muscular dystrophy who get together regularly and play poker. Not sure what else they do. I've heard it's quite a lively crowd. But he really leads a fairly active, normal life. This is not him. This is actually a picture that I stole from Josh Bendit. I think Louis probably rigged up this setting. but it's a young man who has a very similar setup where he has this LTV ventilator on the back and has it hooked up to a bendable arm and an angled mouthpiece that he can keep near his mouth and use it throughout the day as he needs it.
So the volume cycled ventilators can be used for this other non-invasive means of ventilation besides using a mask, and this is with a mouthpiece. So a mouthpiece, these are actually manufactured mouthpieces, and alternatively, some of our younger patients have actually rather wanted to use something that's a little less obtrusive and that wanted something like a straw. So just using an endotracheal tube adapter has worked quite well. The important thing is that all these ventilators are all designed to be used for invasive applications. They're meant to be used for tracheostomies or for tubes that go down the throat, not meant to be used for this purpose. But we do a little bit of modifying in the settings. We don't do anything internally. We don't compromise the ventilator, but we adjust the settings so that the system basically is there for the patient to be able to use, and they simply just have to sip on the mouthpiece, and the ventilator will give them a breath as often as they wish. So it's a pressure, they basically sip to create negative pressure, like sipping on a straw, and the ventilator will give them a breath as often as they want. You just have to create enough flow through here with the back pressure to keep the ventilator from alarming. These are some of the formats. There's the straw. Here's a patient with Becker's muscular dystrophy who works as a computer engineer. He does some really impressive software stuff, but anyway, the important point is that he has some range of upper body motion, whereas this patient does not. So he wanted something that would be with him, and so there's kind of a collar affair with a mouthpiece there that allows him to move back and forth. Alternatively, you can use something like this, and this is a picture of that other patient's chair in the previous photo. This is something that works quite well for some of our patients who are ambulatory, but they need some kind of breathing support during the daytime. So here's a ventilator that's hooked to the bottom of an ambulatory aid with a microphone stand and a mouthpiece, and that allows them to be able to be mobile unto themselves and still receive the ventilatory support. And here's a patient that's doing what you can do with this type of ventilation that you can't do with tracheostomy ventilation. He's what we call breath stacking. He's taking repeated breaths. And if you watch his chest, it keeps expanding. So he's breath stacked. He's taken deeper breaths than he could otherwise do with one breath through an invasive format, and that's allowed him to hyperinflate. And we'll talk about that shortly. So, in fact, now. So this is the second of the three types of benefits that we think are important for ventilation with neuromuscular weakness and what we call hyperinflation, or what's been called previously alveolar recruitment. So why do this? Okay. Well, we know by different studies that if you don't breathe deeply enough, that over time, as you have progressive breathing muscle weakness, that the muscles of basically the chest wall will kind of take a set. It doesn't get the flexibility because you're not moving around, particularly people who just can't get up and move around because their extremities are not as functional. They start to develop chest wall tightness, and as well, the lungs actually, if they're not expanded, start to develop basically, they become more what we call restrictive in the fact that they're not flexible. So if you can do something that actually tries to promote that flexibility to regain some of that, or to, in effect, do what we all do, and that is to sigh, we take deep breaths every once in a while, and that keeps our lungs filled. So if we can keep those alveoli open, keep the lungs flexible, and we can help ourselves out to decrease the potential for atelectasis, we can actually improve that chest wall flexibility. And if you have more flexible lungs and a chest wall, you're not working as hard to breathe relative to the breathing strength that you have. So you want to preserve the ability to do this. So how do we do that? Well, you can do it manually. This is about the cheapest form of respiratory support that I can think of, and this is just incorporating a manual resuscitator with a one-way valve, little circuit, and this can be as long or as short as you want it to be, with a mouthpiece. And what you're trying to do is, in effect, do what that gentleman was doing on the ventilator. You can breath stack.
Just take a big breath in, put the mouthpiece in your mouth, And breathe in, and again, and again, and once more, and let it all out.
And that's basically doing a sigh. And this can be done if a person has even any kind of functional ability to do this. They can self-administer this therapy on their own. I've had people who have done this with a longer circuit, and they use their foot, or you can use your arm, or however you can do it. If you can self-administer this therapy, it's something you can do unto yourself. And so what we try to do is get patients to do these maneuvers, do 8 or 10 of them at least twice a day, 3 times a day if they can. But we ask patients to do a lot of things relative to their busy schedule that don't necessarily work. And so for patients, some of our patients, a subset of patients, have really taken the ball and run with it. It's amazing what they can do. And some of them get a little bit overly aggressive. But the concept is basically recreating a sigh, trying to keep your lungs inflated, keeping that chest wall, do range of motion for the body. How about range of motion for the lungs and chest wall? That's what this is. Okay, and I'm going to stop there, and we're going to move to secretion clearance with another case study.
And so I tend to lump the hyperinflation and lung recruitment in with secretion clearance, which I'll talk about here. So this was a gentleman with ALS diagnosed at age 70. Initially came in with hand weakness. And one thing that was notable in his history is that he had had a salivary gland tumor removed in the past and had radiation, and as a result had a lot of problems with mouth dryness. Patients with ALS frequently have problems with excessive saliva and drooling, and he actually had the opposite, which in some ways worked to his advantage. About 6 months after he was diagnosed, he developed mild orthopnea, so he felt short of breath when he would lie down. And at that time, we checked his spirometry and his vital capacity. It was still pretty good, 70%. But when we did an invasive measure, that transdiaphragmatic pressure measurement that I had mentioned, it was only 10, with normal being somewhere around 70 or so. So he had probably had a very weak diaphragm, but was using accessory muscles quite a bit to generate a pretty good vital capacity. And so based on that, we started him on non-invasive ventilation. He was doing reasonably well. But about 6 months later, developed difficulty clearing secretions. Would tell me he felt like he had a lot of mucus and phlegm that he just couldn't cough out. Back to his salivary gland tumor. So when he initially had that problem with surgery and radiation, the dry mouth, he somehow started using this herbal over-the-counter preparation called alkalol that he would rinse his mouth with, and he said it helped his dry mouth symptoms. So at the time when he started having trouble clearing his secretions, I prescribed a mechanical exfoliator, which you'll see what that's all about in a second, along with a high-frequency oscillating vest. And at first he didn't use either of them. He said, I switched around and gargle with this alkalol, and it helps loosen up any phlegm that I have and can cough it right out. I just don't need anything else. And he actually said, I'm going to give the oscillating vest back because it's just taking up space and I'm never going to use it. And then, unfortunately, he had an episode where he developed some pretty severe mucus plugging, became acutely short of breath. He tried his alkalol, didn't help any. He tried the mechanical exfoliator, still wasn't able to clear the secretion. Then used the high-frequency oscillating vest. And what he describes is he used it and was able to cough up what looked like an oyster, and had dramatic relief, and symptoms were all better. And so from that point on, he used the high-frequency oscillating vest combined with the mechanical exfoliator with very good results, and was able to clear his secretions and did quite well until he eventually got to a point where his secretions and weakness were just so severe that he just wasn't able to tolerate non-invasive ventilation anymore. And he went on to have an elective tracheostomy and was on home ventilation. And unfortunately was really never particularly comfortable and happy with the tracheostomy and ventilator, and eventually withdrew ventilatory support.
So now there's the last leg of the ventilatory support of the respiratory goals of support with respiratory muscle weakness, and that is cough augmentation therapy that Dr. Had talked about. And so when you use this type of therapy, there are a number of alternatives that you can do. You can do manual hyperinflation therapy alone, which we had just seen, and allow the elasticity of the chest and lungs to actually push the air out. We actively inhale, we passively exhale on quiet breathing. If you really hyperinflate the lungs, it's like a balloon. As soon as you let go, the air is going to come out. Oftentimes that can be sufficient to clear the mucus secretions. If that doesn't work, you can use hyperinflation with an abdominal push or thrust, also a compression. You can call it a compression, but the point is that you actually, here you're doing the inspiratory phase of the cough, augmenting that. In this case, you're augmenting both the inspiratory and the expiratory part of the cough by pushing the air out after you've maximally inflated. And the alternative to those two therapies combined is mechanical inexflation. So look at the manual cough augmentation first, and this is what's called a quad cough maneuver, where the hands are put below the rib cage, and they can actually be put down as low as the lower abdominal area, particularly if you have a gastrostomy tube. You don't want to traumatize that area, but this certainly can be done. And you basically thrust after you hyperinflate, and what the hands do is act as the abdominal muscles to be able to force the breath out. It also splints that area because people who have weak abdominal muscles but stronger chest muscles sometimes try to cough, and the force comes out through the abdomen. So you need to kind of what we call splint that. This can be very helpful, but it does require a skilled caregiver in order to coordinate the effort of inflating the lungs and then pushing the air out. And it is dependent upon how much air you can get in. You're only going to get as much force on exhalation as you can benefit from by the amount of air that's
We'll first use a pillow to stabilize the head. Check for optimal body position. And landmark for the assist. Take a big breath in, put the mouthpiece in, and breathe in, and again, and again, and
So that's a combination of the hyperinflation with the abdominal thrust. This can be done, actually one person can do both things with a patient. It does take some skill, and the whole process in terms of the best benefit is coordinating those two efforts in order to maximize the peak, what we call peak expiratory cough flow, because it's the peak velocity of air expelled that really clears the mucus secretions. So the other alternative to using manual means, of course, is the mechanical inexflator. I like to think of this as kind of something that provides the reverse of what we do with a cough. We take a deep breath in, the vocal cords close, and then we build up pressure in the lungs by compressing the abdominal muscles, and then the vocal cords let go, and then we expel that breath out. So what this machine does is it helps you to take a deeper breath than you can on insufflation, positive pressure to inflate the lungs, and then there's an immediate pressure change to exsufflation to actually pull the air out. Feels really weird. And of course, the teenagers that we have in clinic, oh man, I hate this thing. It's like, and I'm not going to use that. Boy, when they get a respiratory infection, this becomes their best friend, because this is really the most efficient means of improving or augmenting cough relative to the other manual alternatives. I'm not going to spend any time on this in order to be able to get through everything, because we're running a bit late and want time for you to be able to see everything out in the demonstration area. But the cough assist device has adjustable inexflation pressures, and this is the kind of device that needs to be basically provided to someone by a clinician that has experience using this device, because it's important to get the right pressures set up in order to get the best benefit to the therapy. So there's a significant amount of work that's been done with pediatric patients as well. So it can be used both in a pediatric arena with smaller pressures or lower pressures, as well as an adult pressure setting. This type of machine, the company that produces this, Respironics, has a video, an educational video, that I think should go with every machine. So if you ever get one of these things, or even if you have one already, ask for the video. This is very integral to allowing the caregivers at home to be able to be able to use this to the patient's best benefit. This is just an example of how it's done.
in, cough, out, out.
And you can see the, oops, darn, I did that. So can we do that one more time? Or maybe we can't. So you watch the chest wall excursion. You can see how the machine really inflates the lungs and then pulls the air out.
In, cough, out, out. In, cough, out, out. In, cough, out, out. In, cough, out, out. In, cough, out, out.
You can see when this is used, the patients, they don't have to let all the air out at once. Some people think like, oh my gosh, it's just going to pull the air out. I'm not going to have a breath. It will allow you to control your cough. You can cough, cough, cough under the negative pressure to pull the secretions out. For some of our patients, who particularly are Duchenne patients, some of them have what we call macroglossia, kind of an enlarged tongue. And oftentimes the tongue itself is quite weak. And with negative pressure, that tongue can actually get in the way and block the ability to pull the air out. So what we've done is to try to integrate a mouthpiece with a mask so that basically the tongue stays under the mouthpiece and stays out of the way so that we can actually use the therapy. So it's just one of those little tricks that you try to do in order to basically make the therapy work in spite of a problem. We're us respiratory therapists are meant to be kind of problem shooters and figure out how best to make the therapy work for the patient. So that's what we do. So the enlarged tongue, muscle weakness, the mouthpiece basically acts, again, to block. I'm talking ahead of myself. So alternatively, you can use this for invasive ventilation as well. So if a person has a tracheostomy and they're used to getting catheter suctioning, this type of therapy can be used to clear secretions. I consider it to be much more optimal. Catheters only clear secretions immediate to where the catheter is placed. That catheter can be very irritating to the airway because we have cough receptors, and most people will cough when that catheter is introduced into the airway. So when you're using a cough assist device, you're just pushing air in and pulling it out, and you're pulling secretions from a lot farther down into the lungs than that catheter can otherwise retrieve. So it's much more well tolerated by the patient. And what we find is that because you can pull secretions out from much farther down into the airways of the lungs, that the need for doing any kind of suctioning or clearance is less as opposed to catheter suctioning. And you have this decreased stimulation problem because when you do a lot of catheter suctioning, you can actually stimulate more secretions to be produced, and so this can kind of break that cycle. And again, with catheter suctioning, you're putting a catheter down there. Oftentimes there's trauma to the airway. It's what we call the mucosa, the surface area tissue of the airways is very tender, and we don't want to cause disruption. And if you use this with a tracheostomy tube, you can actually ventilate. You're giving a breath in and pulling it out. So you can actually just give positive pressure and let the patient passively exhale. So you can actually use this in conjunction with cough support or just to clear secretions as well as to ventilate the patient. Alternatively, when we talk about secretion clearance, there's two different things you need to know, and people get them mixed up quite often. There's cough clearance and there's what we call mucus mobilization. People with neuromuscular weakness generally don't have what we call intrinsic lung disease, any kind of a disease internal in the lungs that affects what we call the mucociliary escalator. We all produce mucus. It gets spewed into the airways by glands that line the airways. We have cilia that move that mucus up. Mucus, I like to call it liquid flypaper. It captures all the impurities in the air that we breathe and moves it up through the generations of airways until we cough and clear it out. If you don't have intrinsic lung disease that affects the mucus movement, then the limiting factor for neuromuscular weakness is the cough. And so if the cough assist device works well enough unto itself, that may be all that you need. If you have some kind of lung disease that affects your ability to be able to clear the mucus or to move the mucus up, then you need some kind of mucus mobilization therapy. Or if you develop mucus plugging, the cough assist device isn't doing the job, then you need to add some additional therapy. So it's really an adjunct to the cough assist device. And we're trying again to mobilize secretions if that disease is affected, if you have a disease that's affecting secretion clearance. And the key important thing here is that you do this in conjunction with cough augmentation. You don't want to be mobilizing a lot of secretions and get those secretions moving up to the upper airway, and then the patient can't clear them out. So this is integral to that. So one more case presentation.
One more case.
Sorry.
So this is highlighting the issues of invasive ventilation that sometimes come up. So we put a lot of emphasis on non-invasive ventilation, and I think both Louis and I are big proponents of it, but there are times when it doesn't do the trick. So this was a patient that I first met when he was 23 years old. I only met him because he came to the emergency room with shortness of breath and had a collapsed lung. He probably had pneumonia. They went to put a IV into his neck and caused a collapsed lung. But it turns out that he had respiratory failure with a carbon dioxide level of, I'm not sure if I put an extra 1 in there or not. It was definitely elevated. I'm not sure it was that high. But at that time, he was admitted to the intensive care unit, had an endotracheal tube inserted and put on a ventilator, and at the time did not want tracheostomy. He eventually had his collapsed lung treated, his pneumonia treated, and was able to be removed from the ventilator and put on non-invasive positive pressure ventilator with fairly low settings, an inspiratory pressure of 8 and an expiratory pressure of 4. So as Louis was talking about this idea of high span, this is only a 4 centimeter of water difference between inspiratory and expiratory pressure, so not very much support, and not terribly surprising, had a CO2 that was still elevated at 60. Fortunately or unfortunately, he and his family are fairly independent and live about an hour outside of Baltimore in a fairly rural area and don't like to come in for visits. And so the first time was back in February of '02. Now in March of '02, he was hospitalized again with this time his lung collapsed on its own. He required another tube to inflate his lung. And while he was in the hospital, we increased his inspiratory pressure to 10. He finally did come back for an outpatient follow-up, and his CO2 was better but still elevated at 50. But he was feeling good and was using his non-invasive ventilation at night. So a year after his initial presentation, we managed to get his inspiratory pressure increased to 14, and he was really using it 24 hours a day. Unfortunately, in July of that year, he was hospitalized again. His CO2 had risen to 68. We increased his inspiratory pressure from 14 up to 18. And a lot of people who saw him were kind of surprised if people who weren't used to seeing people on non-invasive ventilation sort of round the clock. He had gotten very used to it. He was able to coordinate his breathing so that even though he had this nasal mask on, he could speak and eat and do everything very comfortably with the mask on. But because he was developing some confusion and his CO2 was elevated, he was intubated and underwent an elective tracheostomy. About a month later, he went home, and he actually told me that he was so happy to have this mask off of his face. Now he just had this tracheostomy down around his neck. It was much more comfortable for him. So as of went about 6 years with no hospitalizations and was really doing quite well. He would go on vacations with his family to the beach, and we really heard very little from him. Unfortunately, he has had a couple pneumonias since and has run into some problems with skin breakdown, but he's back home and last I heard doing pretty well.
Thanks. So tracheostomy ventilation, again, invasive form of ventilation. What indications would we have to do this? Well, again, the development of bulbar weakness where mask ventilation is no longer a viable alternative would be a significant factor indication. Or non-invasive ventilation itself being no longer well tolerated by the patient or not being effective enough. So these are all things where kind of cross the bridge here, or we're going to have to cross the bridge. What are we going to do? Do we want to, we're no longer effectively supporting a patient. We need to determine, what is the best way to go with this? But in the end, it's the patient that needs to make the choice as to undergo tracheostomy ventilation because we're talking about invasive ventilation. And this is a decision tree. I mean, again, as I said before, it's our responsibility to tell patients about the different types of, or their type of neuromuscular condition and what's going to happen to their respiratory function, and then give them all the alternatives and let them decide unto themselves what they want to do. One thing I want to just touch on outside of ventilation, but it's also pertinent, is another management issue, and that is what we call home oximetry monitoring. With the advent of these oximeters like Dr. Lechtzin had shown, these are available from different internet medical suppliers for around $60. 2 or 3 years ago, that wasn't the case. They were hundreds of dollars, and oftentimes you had to get a prescription to get one. They aren't supportive. Payers rarely support oximeters. But what we've found is that we've integrated or tried to embrace a kind of a protocol, because we know that one of the biggest problems people with neuromuscular weakness have is that when they develop respiratory infections, that usually cascades into more problems, and oftentimes they end up in the emergency room because of shortness of breath. So what can we do to try to use a first early indicator of what's happening? So the indications for using the monitoring are either or both developing hypoventilation, where you're no longer getting adequate ventilation and you may not be aware of it, or developing a respiratory infection. The protocol is to use the oximeter, I should say, and the kind of cutoff value is right here, 95%. If you can't maintain an oxygen saturation of 95%, you're either not getting adequate ventilation or there's some developing pulmonary or lung congestion going on as a result of the respiratory infection. And if you're having any symptoms of a respiratory infection, our protocol, getting ahead of myself again, the plan is to use your non-invasive ventilation more so, to use whatever cough augmentation you have, and also to get, at least in our case, we prescribe through the patient's community pharmacy a broad spectrum respiratory antibiotic to try to bridge the gap. Basically, this care plan for us has, I think, really helped, because we rarely have neuromuscular patients that are admitted to the hospital for respiratory distress as a result of pulmonary congestion associated with an infection. So it's a very simple protocol. It only requires about $60 or so to get an oximeter. Make sure if you were to get that, get one that's FDA approved for human use. And make sure you understand, no, because there are veterinary use. Okay, so understand that this is a non-invasive monitoring device. It's only as good as what it has to work with. If you have poor perfusion to the hands, your hands are cold, you don't have good circulation, the machine is not going to read well enough. So you need to make sure that you have good perfusion to the hand. If you don't, put your hand in a cloth with hot tap water, let it warm up a little bit to open up those vessels and try to get some circulation going. But again, it's a cheap means of basically kind of self-monitoring at home. So we find it to be helpful, and again, it's kind of an empowerment to people. It allows them to be able to kind of self-monitor themselves, and I think that's important. It's not just us, it's our association with you in trying to come up with a good plan that supports you. Now, this is one thing that I wanted to tack on today, and this is glossopharyngeal breathing. Talked about ventilators going out, or what happens if you don't have power. This is a way of breathing with oral muscles that you can do unto yourself. And what he's doing is glossopharyngeal breathing to maximal inhalation, and Carol's using a manometer, and he's going to blow out. And I think that's about 3 to 4 liters of air that he's basically swallowed. It's air gulping to get air in. The esophagus is sealed, but the airway trachea is open, and if you do what's called glossopharyngeal breathing, it's also called frog breathing, you're swallowing air in. I've seen people do this who have incredible proficiency at it, don't even look like they're working that hard, and they're able to just breathe well enough on their own to do this. So it's just a kind of some people have used this as a kind of way of breathing on a regular basis, but it's an incredibly powerful alternative that you can do unto yourself as a way of supporting your breathing if the machine fails for whatever reason or your power is off. So one last thing, some resources that you can take a look at. Then again, the International Ventilator Users Network is a fabulous resource for different issues and support group for people that are using either invasive or non-invasive ventilation. If you aren't aware of it, please look it up on the internet. Post-Polio Health International is also in conjunction with this, and this is important too. They do have a separate website though, right, Joan? Yes. So, look to this, right? And then this is a program that I think everybody needs to look at if you're using any kind of non-invasive breathing or invasive breathing support. It's called Take Charge, Not Chances, and Helen Kent was one of the contributors to this effort that I think is fantastic. It's actually 4 parts, right, that involve basically home emergency contingency, developing, having a kind of a medical information, basically a sheet on yourself that allows you to have all your medical information if you have to go into the hospital. And also, there's a sheet that actually explains to care providers in the hospital that oxygen is not necessarily appropriate, that ventilation is what's appropriate if a person comes into the hospital. So this is a very powerful set of papers, I think, that everybody needs to have and to actually use by integrating the home emergency contingency as well as to write out the medical information so that you have all these things available. Hopefully you don't need them, but it's part of, again, kind of taking care of business on your own part. Okay? And the video clips that we saw are from Dr. Doug McKim and his respiratory therapist, Carol LeBlanc, and this is through the Ottawa Rehabilitation Center, and they have a website with a lot of resource information as well. So if you are interested, I'd look at those sites and you get more information about your own best respiratory support. And I think I'll leave it at that. So, and I know we're over time, sorry.
Thank you, gentlemen. Great. I think we'll forgo the question and answer period because we are almost out of time. We may get kicked out of this beautiful place. I'd like to introduce Diana Guth and Helen Kent over there, who have tables in the exhibit hall with all the masks. Yes. They are, if I could clone them, I would, because they are the 2 best RTs for, well, without Louis too, we'd clone Louis, but they know their masks and they know how to fit them. So if you have any questions or you want to see the masks, please go out there. Louis is going to do a demonstration of that mouthpiece ventilation that he showed, and he'll be at the Newport booth out there. The Take Charge, Not Chances pamphlet that he talked about is at the Ivan table out there, so there's lots of stuff to pick up if you haven't already done it. So again, thank you to these wonderful people. Thank you to Gladys. Is she still in the back? Thank you, Gladys. And Rick's there. And thank you all for coming.